Great. Good afternoon, everyone. We wanted to welcome you. I'm Catherine Gaston, a perinatal consultant for the Champlain Maternal Newborn Regional Program, what we often refer to as CMNRP. So if you're not too familiar with CMNRP, we are a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. Our extended network include representatives from hospitals, midwifery practice groups, public health units, community health centers, birth center, and other community agencies that all provide perinatal and newborn services. Today, we are really happy to collaborate with Leslie Sabourin and Dr. Stephanie Benzenten from the Rogers Neilson Children's Hospice to present the webinar, Community Connections, Enhancing Care Delivery in Perinatal Palliative Care. Just a few reminders before we get started. This webinar is being recorded and therefore will be available on the CMNRP website in the coming weeks. We also encourage all participants to put their question in the Q&A section, as there will be time to go through all of them at the end of this webinar. Before we get started, I wanted to acknowledge the land where I am located today. Ottawa is built on the traditional territory of the Algonquin Anishinaabe Nation and home to many diverse First Nations, Inuit, and Métis people. We recognize that Indigenous practices of health and well-being have been in place since time began and are maintained to this day. There is much work to be done to honor Indigenous women's, families, pregnancy's journey, and bring reconciliation to healthcare in this region. Let us move forward together with kindness, humility, and respect. So I have the privileges of introducing our guest speaker today. I will be the moderators to help with the Q&A at the end. But today we have Leslie Sabourin. She has a diverse career in neonatal and pediatric nursing. She began her career in a high-risk labor and delivery and ICU. And perinatal loss and palliative care became her passion very early in her career and took a lead role in the perinatal bereavement and palliative care team program as a bedside nurse in the NICU. Presently, she is the perinatal palliative care coordinator with CHEO Palliative Care team at the Rogers Neilson Children's Hospice. And Dr. Stephanie Benzenten is a proud Maritimer who completed her medical school at Dalhousie University in Halifax, Nova Scotia, before moving to Ottawa to complete her pediatrics residency training. Following that, she completed an additional year in pediatric palliative care team and pain and symptom management here in Ottawa. She's one of the physicians on the CHEO Palliative Care team and does some general pediatrics as well. So welcome everyone, and I'll leave it to Leslie and Stephanie to get us started on the webinar today.
Awesome. Thank you so much, everyone, and welcome. We're really excited to be here. Our goal today is to hope that you, after sort of hearing this presentation, is to gain an appreciation of our perinatal palliative care program model. And specifically, what we're focusing on, obviously, is how our program can support community providers like yourselves in terms of also supporting the needs of families who are facing perinatal loss, but also provision and support of practical tools and educational resources for care delivery in the community. We also hope to plan to discuss developed strategies for effective coordination between community hospitals and specialized perinatal care teams at tertiary centers. And we hope that you feel free to ask questions, pop them in the chat. We really want to leave lots of time for discussion as well as we go through our talk today.
Yes, hello everyone. Oh, I missed one. So sorry, I need to go back. So just want to tell you a little bit about where Steffi and I are from. Obviously, we both work on the CHEO Palliative Care team, but wanted to brag just a little about our amazing hospice. Roger Neilson Children's Hospice is located in the grounds of CHEO and provides services to the children in our community with life-limiting conditions. Some of the programs that we offer at the hospice are respite care for families to get a break as Their kitties are can be very complex, and it also gives an opportunity for us to get to know them and really understand how the child's doing and how their family works together as a team. Symptom management is certainly a big part of what we do, caring for children as their disease changes potentially, or taking opportunity to keep children out of the hospital can be a goal for that as well. Transition care occurs when um, if a child has had a new procedure done or something like either a G tube or potentially a trach, they can actually transition through the hospice before they go home, just for a little bit of extra support. Recreational therapy is an amazing program that we have within the hospice where our rec therapist provide an environment that is um, full of love and fun and really focusing on the quality of life of our children. And they also have a very unique set of skills to speak to children about death and dying. In addition to that, we have visiting home hospice where we have amazing volunteers going into our families' homes to help. End of life care, of course. And a huge part of what we do is our grief and bereavement support, so our grief services within the hospice. And then, of course, the perinatal palliative care program. And there's a link here to our website that certainly goes into all of these things in more detail. So I'm going to potentially annoy everyone and read you a definition. We love definitions that really pull all of what we do together. And this is one of our favorites, and it's from Together for Short Lives. It's a UK based support that really does have a wonderful way to describe this. And really, what is perinatal palliative care? And palliative care for babies with a life-limiting condition is an active and total approach to care from the point of diagnosis or recognition throughout the child's life and death, embraces physical, emotional, social, and spiritual elements, and focuses on the enhancement of quality of life for the child and supports the family. It includes the management of distressing symptoms, provision of short breaks or respite, and care through the death and also bereavement. So we wanted to talk just really briefly about life-limiting conditions. So what types of families are we meeting? When we are definitely seeing families that are diagnosed either antenatally with a fetal condition, a life-limiting condition, or postnatally. And these are conditions which the risk of overall survival is low or, really uncertain. Conditions with high morbidity, including certain genetic conditions like trisomy 13 or 18, conditions such as renal agenesis. Referral sources that are typically, or maybe the most common one I would think is probably our MFM clinics in the community, our high risk maternal fetal medicine clinics, but can often come from geo specialists, specialties such as genetics, cardiology, potentially metabolics, obviously in ICU, and then the community, so obstetricians in the community and midwives. So life-limiting conditions are really conditions where we anticipate significant shortened life or significant morbidity, and we're not really surprised if death may happen or occur in utero or shortly after death. Life-prolonging interventions are maybe not desired by the family. There are certain conditions that an example maybe would be a hypoplastic left heart syndrome condition where it can be deemed really burdensome and a really complex decision to undergo like many years of surgeries. And there's a lot of really difficult things for families to consider in those situations. And then when the trajectory is uncertain, we certainly would want to meet families in those situations as well. And what we find within our referrals, families may want to continue their pregnancy when they find out about a life-limiting condition, or there's the possibility that their choice would be to end their pregnancy at the time of diagnosis. And we support families in both situations from that time of diagnosis. We have, it's really applying a very similar model of care to both situations. We know that families have a really hard time with both. And we make sure that we are supporting all families within those decisions. And we certainly families who are uncertain about their decision making, and like being part of that process with families is something that we can offer as well, and getting a better understanding about what perinatal palliative care is. And, detection of any life-limiting condition following birth. Um, those children who are babies that have had either a traumatic birth or an insult during pregnancy or shortly after, we're being referred to those children as well.
Yeah. So, and I think the other thing that's important is if there's ever like uncertainty or a question if someone is appropriate for us, we're happy to always, you know, be reached out to chat about a referral, because we want to be a support, even when it's not clear. Um, Leslie mentioned a lot of some of the big categories of the types of patients that we were receive in terms of referral categories. I do like this slide again from Together for Short Lives. It's their perinatal pathway, but that sort of categorizes the different types of infants and babies who may benefit from a palliative care referral. And so the first category would be those that are where there's a life-threatening condition for which curative treatment may be feasible but can fail. And so this would be like extreme prematurity, congenital heart disease, where there are things and interventions that can be done with the goal of trying to minimize or cure the disease, but that it is also possible that these will not be successful, or that there will be an acute crisis or events along the way. For example, especially with extreme prematurity, where you know receiving palliative care support may actually become a bit more prominent in these cases. They may reach long-term remission or unfortunately need palliative care for end-of-life care support. But this would be an example of some of the types of conditions that our team sees. The next is the conditions where premature death is inevitable, so that where there can be periods of long intensive treatment aimed at prolonging life, but that there um, uh, isn't always uh, a lot that can be done to delay that, or where death is inevitable. So this would be some of the chromosomal abnormalities, um, bilateral multicystic dysplastic kidneys, for example, renal agenesis bilaterally. And then the other category is the progressive conditions without curative treatment options, where the focus is exclusively palliative care approach, like the anencephaly and some of the severe neuromuscular disorders. And then the last category is one where we talk about irreversible but non-progressive conditions that can cause severe morbidity or disability, leading to susceptibility to health complications and likelihood of premature death. So this would be, for example, the severe hypoxic ischemic encephalopathy or severe HIE with subsequent development, for example, of severe cerebral palsy and complications that arise secondary to that, the severity of their cerebral palsy. Um, and so this is a way of categorizing different types of conditions. And this would be a similar approach that we would use for pediatric conditions as well, actually, not just the perinatal ones, but it is just a framework that we like and makes sense.
So just to look a little bit at our model of care, we have an interdisciplinary team approach, of course, with our program, including physicians, nurses, social workers, rec therapists, spiritual care, and collaborations within our community partners as well, developing pathways and medication guidelines, which we're going to talk a little bit about soon. When we meet families, we're meeting families with the team, and with social work potentially meeting them with spiritual care at the same time, and with the physician team and nursing. And we accompany families along their trajectory of their baby's condition. And this would be through pregnancy and birth, and into bereavement, or potentially in the NICU and beyond. We spend a lot of time really getting to know families and helping them redefine their hopes in a situation that just feels definitely hopeless in many experiences. We know that hope releases positive chemicals in our brain, and the literature describes that hope really shapes our well-being and our quality of life, and it can greatly assist our families in really helping them with decision making, and then improve their coping and enhance their gratitude about aspects of their situation that there's hope to be had in. And we spend a lot of time with families redefining and reframing these hopes for their baby. We document all of this, and we create a story and plan for families through specialized birth planning, which focuses on the wishes and values of families. And this also includes advanced care planning. It will indicate the family's wishes for when the baby is born and what that looks like and what we can do to support. And often we will work together with the NICU potentially to support this family in the way that makes sense for them and for their baby. We spend a lot of time on making memories and really honing in on creating meaning in this situation. We know that creating meaning and can be very positive for families' grief in the long run. So we discuss and meet families initially focusing on the time that they had with baby in their pregnancy, potentially pregnancy pictures, making memories, creating moments in that period of time, recording the baby's heartbeat. And then we build the plan around the memory making for their legacy after the baby is born. And then Roger Neilson Children's Hospice has a robust grief service support for families in our community and beyond. We will review this more shortly. And then we also certainly want to be a support for the providers in our community. These can be really distressing situations and sometimes cause moral distress within our providers. And we, as a team, really want to be able to support nursing physicians in these situations.
Yeah, and I think one of the key things as part of our program and our model is we recognize we are very lucky to have the hospice and as a physical resource where we are, but we also know and really value that really high quality palliative care can be provided in multiple locations and in any location. And so really our role in supporting community providers has always been something that's extremely important to us. And there are different ways in which that can look. So sometimes, for example, typically for older patients, but we might get uh, a phone call about a patient from a provider in the community saying, would this be a patient who's appropriate for you to see? And we're like, yep, happy to provide a consult. Or we can provide phone support as needed to people who are providing palliative care to children in the community where they may not have pediatric palliative care specifically. So in terms of how we can support people in the community, we are always happy to receive a consult and meet with a family and provide guidance, meet with that family and provide guidance on care planning and decision making outlined in the way that Leslie described. And that we are also happy to do that jointly with other providers, or if there is someone who is in an outlying community and the goal is for that person to stay in their community, we are happy to be flexible in the way in which we can provide that support. If, for example, there's an antenatal diagnosis of a life-limiting condition and the decision is to stay close to home for all the remainder of the pregnancy and care and delivery, then we can provide support to the providers who are involved in that patient's care, as in addition to the family, um, and help guide the decision making piece and what does care look like in different environments or when there's uncertainty, for sure. Another big part, obviously, of what we do is education. And so we have done lots of outreach and continue to do lots of outreach in terms of presentations or training for community providers about how to provide end of life care, how to address um, family and family concerns or common questions that come up. Leslie's done a ton of outreach that is sometimes done in person, sometimes can be done virtual, depending on where the ask is coming from. But that is something that is always important to us. We and are always happy to offer. So if this is something that your specific center or group feels would be beneficial, please don't hesitate to let us know. And education around family support. And we'll go through some of our resources that exist in a little bit more detail. but we want everyone to feel empowered to be able to have resources and develop a skill set to help support these families in a way that's supported by our team as needed. In terms of resources, we'll go again, like I said, we'll go through these in a bit more detail, but our team has sort of developed some resources that we have designed and created with the aim of them being like practical and useful for providers who are not in a tertiary care center, where these cases may come up infrequently or few and far between. And so this includes kind of like toolkits, medication protocols, and support materials for memory making and things like that, that could be done anywhere. So we will chat about that a little bit more. And then the emotional support piece of, sometimes there's a really tough case or questions arise afterwards or ahead of time, and we are happy to support teams who need or who feel like they would benefit from just talking through a perinatal palliative care case. So like Leslie is a great resource for that as well. So, I think we hope that the message is that please reach out to us if you have questions. There are no silly questions. It's okay to ask the same question 20,000 times. We are here as a support, and we want to support you in supporting the patients you're looking after.
We certainly cannot talk about any care in the community without talking about our amazing CHEO critical care transport team, who based out of CHEO, of course, and who we are able to collaborate with and support in ways that are beneficial for families. So CHEO, this team is a CHEO-based team, as I had mentioned, and that actually does now not only neonatal, but also pediatric critical care support within the community. And it's 24/7, 365 days a year, and really is a support that is immediate and can be via phone or potentially dispatched to provide bedside care. And in these situations, a critical does remain the initial or the first call or point of contact from outlying centers, and then the involvement with the transport team continues after that as needed. I just wanted to see if Dr. Redpath wanted to mention anything or add to this slide, who is the physician on the transport team, and we're really happy that she's here. So if you have anything to add, please do.
So I think just trying to, can you hear me?
Yep, we can. That's great.
Okay. Hi, yes, Dr. Redpath here. So I think I'm just, Leslie, my understanding is a couple of slides here, or would you like me to?
Yeah, I don't
to go.
I don't know if you want to discuss the process specifically, like the critical process, and if that's needed.
Absolutely.
Or...
Absolutely. So I think most of you are familiar with me. As I say, I'm Dr. Redpath. I'm Medical Director of CHEO's Critical Care Transport Team. And we've worked collaboratively with our palliative care partners for some time, but this has certainly been within the domain of the hospital, and usually when patients arrive back at CHEO. So again, I think many of you are aware of how we function. We're contacted through Critical Ontario for support, whether that's in resuscitation and or post a delivery, and now into pediatric care. So we will we're triaged in this capacity and dispatched as soon as we can be and come to support. And again, many of you are familiar that we are, the goal would always be to take patients back to CHEO, but unfortunately, this isn't necessarily the best practice based on diagnosis or care as it proceeds, especially with the longer distances. So we have undertaken a collaborative project, which Leslie, I'd like you to speak a little bit more to with our partners, led by Leslie and Stephanie, to develop more of an outreach such that when we have to leave or we have to be dispatched to the next case, that we have an ongoing support arm for both families and healthcare providers in the community, cognizant that these events are rare, these events are very challenging, and we want to do our best to continue in the entire process, from resuscitation to events that may occur afterwards. So I don't know, Leslie, if you want to, I'm happy to speak to this slide. I just couldn't remember which came. So
That's okay.
again,
Absolutely. Go ahead.
So this is a CMNRP webinar, and you're all familiar with CMNRP's region. So we cover, but as a CHIO transport team aligned to CHIO and covering the province, we also have to cross-cover our partners. So we travel an expansive distance, up to 440,000 kilometers squared. So we go as far north in the province of Ontario up to Fort Albany. And we also go into Quebec. So again, as many of you have experienced frontline, there is often a delay, both in the geography to get to you, but also just serving the entire community and patients and triaging. So while we'll do our best to respond, I think it's important just to sort of always reflect on the expanse that we're trying to cover and the number of partners and patients who may be required. Hence, again, dispatching to the next case and what sometimes feels like leaving you in the lurch. So this is a great collaboration such that this never appears to be the case.
Thank you very much, Stephanie. I appreciate that.
And so addressing the situation where there's a delivery in the community and their goals of care change, or there's an imminent death or a death has occurred. And so we just wanted to chat through that a little bit, and then I will call on you again, Stephanie, or any of the members of the transport team to sort of share examples if you feel it's appropriate of times when you guys have had lived experience with this. The things can shift quickly, but once the critical is made and the connection is made, it is possible that a death or end of life may occur before the critical care transport team arrives, during the transportation, at CHIO, or while the transport team is in the outlying community, and it is clear that goals of care are shifting to a more palliative approach, or that death is imminent, or a death is occurring. And so, how do we as a team best make sure that everyone in this situation is supported? And this collaboration really came out of wanting to feel like we were supporting the patients and the families, but also the transport team in feeling like we are providing a bit of a broader layer of support in terms of for those who remain in the community. So in the example, for example, that the transport team arrives in the community, and that patient is going to stay in their local hospital where the patient was delivered, for example, because they anticipate, it's very clear that the baby is not going to survive very long, and it's a palliative approach to care. As is always the process, the first sort of line of communication is with the critical care transport team, but the transport team is absolutely can reach out to us and consult us, call us as the on-call pediatric palliative care physician as needed to provide recommendations or additional support, should they feel that that's required. And that's true for the patients who are admitted in the NICU in Ottawa as well. So this is a relationship that is already established, but is one that also extends to the patients that the team is looking after in the community. And what we have developed, and we'll go through a little bit more, are some of the specific perinatal palliative care resources that were redesigned, or not redesigned, but repackaged in a way that they are usable and practical for the community, hopefully no matter where someone is, and just making sure that the resources related to grief support are out there, so that can be offered to families who are undergoing the loss. I don't know, Dr. Redpath, if you have any, if you wanted to speak to any sort of like specific examples where this sort of came out of, or types of examples, since you guys have that experience.
So happy to. I mean, I think, even within the last year, whenever you ask the team, do they have any cases to relate? There are several that come to the forefront, including just difficult cases in context of families and family care supports when we're moving patients as far as they are. I can certainly relate to, we had a pediatric case that was a very difficult resuscitation in a provider hospital within the city that the team were dispatched to. Now, fortunately, we had a PICU fellow on rotation with us, and our transport team and all of the physicians at this facility tried their best, but were unable to resuscitate this child successfully. The transport team then had a subsequent call that they had to leave immediately for, and you can imagine what that's left with ED adult providers in a facility that doesn't necessarily have the social work support consistently or aligned with how we might undertake at CHIO. So again, a partnership like this would allow our transport team to triage onto the next case and enable some of these follow-up resources and or care providers to be consulted and continue support that the family need. Another one that, again, fairly recently is a very, very unwell respiratory distress up in the north, again, with healthcare providers less familiar with the withdrawal of care conversations when they're providing care for all ages and stages. Again, I think another key issue that we're faced with in transport and managing such a large region is that over 60% of our providers are non-pediatricians. So they're family physicians, anaesthetists, ED docs, and again, social work support within hospitals isn't necessarily consistent either. So that was a withdrawal of care, just not stable enough to move. How this is currently managed and managed the longest time is that I'm sure most of you are familiar that we will continue to support always, we being both the team and the neonatologist as our time allows, and follow up with physicians. And we're happy to have 3-way speaker conversations, to involve the family when care is not, we're not unable to save a child or a life. Unfortunately, we will undertake that. And we will also support medications and processes. But we ourselves are managing in-house ICU emergencies, and so it's challenging sometimes, as well as our expertise isn't necessarily in that domain, given how we work so collaboratively in the hospital with Stephanie and the team. So these are just a couple of cases just to relay some of the challenges the team feel in the moment when they have to leave, and it's just a mess. It's all just a mess. So I'll let Stephanie speak to resources that we've worked together on that will really support you, your healthcare providers, and most importantly, our families.
Yeah, thank you, Dr. Redpath. Yes, so these situations can be so challenging for our providers in the community. And so together as a team, in collaboration with the transport team, we developed a document that for providers that addresses some of the things that can be really challenging for providers in these moments. And there's information in here on how to be with families. How do you sit with families during these really difficult times, and make considerations around memory making and have a good understanding of what the benefits are of memory making. So this can be relayed and normalized with families, and creating meaningful memories in that time if possible, especially in the perinatal world, but also in the pediatric world as well. There's also a section that is quite in depth around caring for a baby at end of life, that talks about symptoms that a baby can potentially experience, and the medications that we would use in order to mitigate any of these symptoms. There is a link here to the pamphlet itself online, and there are some hard copies too that will be accompanying the transport team in the community. But if anyone in the community would like actual copies, we can arrange that as well.
And I think actually the link is also in the chat. I was seeing that there was Gabriella Speck from the transport team. Did you have a comment that you wanted to add?
Hi.
Hi.
No, we don't have any comments. We were just taking a look at the pamphlets as well in the background here. And yeah, we will be carrying them with the teams going forward so that they can pass them out if needed.
Awesome. Yeah. And they're always available online also, but yeah, that we hope that our goal is that they are a useful resource. And if obviously over time there's any feedback about them or anything that is missing or needs to be changed, please also don't hesitate to let us know, because we always are looking to make things better.
That's awesome.
Thanks. So when we talk about providing end-of-life care to a baby, like I said before, like high quality palliative care can occur in many different settings and does not require a hospice or a tertiary care hospital to provide good end-of-life care. It can be done anywhere. And so it's not about the four walls. It's about the approach and support. And so um, really the thing that my approach always is about, you are talking about difficult things, giving bad diagnoses or news, and that there's no way to take away that it feels awful and that you wish this wasn't the case and that the outcome is not what we wanted. Like, we can't change that part of it. But the way I try to always reflect and communicate is with compassionate honesty. That is how I think that is our role, is to be honest as compassionately as possible, even though the information is hard. When we talk about the resources that are included, the information in the resources, it includes the management of symptoms that we commonly anticipate at end of life. And so we'll go through what those are over the next couple slides. How to do a pain assessment and common specific medications that we use at end of life for specific symptoms with doses, because that is, we also know is we want to take away that as a source of distress, or if someone faced themselves with a situation where maybe the transport team wasn't there, or there was they lost the line that the transport team, for example, had put in. So just an approach to how to deal with those situations, as well as non-pharmacologic interventions, and obviously the contact information for Leslie, who is our unbelievable perinatal palliative care coordinator. So when we look, this is what a picture from the pamphlet, but it looks the way the medications were designed. And there was a big committee that came together that included neonatologists, pharmacists, palliative care, important stakeholders to put this together. But the goal was, so for sure, if you are in the NICU, or maybe if the transport team has come and or someone has placed an umbilical line or has an IV, there may be different ways to give medications through IV or otherwise. But the way this particular recommendation and medications were designed were for the situation where you don't have IV access, you don't have a UVC. And so looking at what are the non-invasive routes that we can give, like the initial steps of symptom management for a baby at end of life. And so that this could be done in the delivery room, on a postpartum ward, with the types of medications you would already have there. So there is a morphine oral solution, a 1 milligram per ml oral solution, which is great. We use it all the time, but you're not going to find that quickly on L&D. That may need to be compounded. So that's not, so those suggestions are there, but we were really trying to think through what is readily available where babies are born in all sorts of different communities. And so that was the approach. So this is very weight-based. This is all done by weight. And so it's a bit more generalized. And so obviously if the transport team is involved and is providing other recommendations, then we would go with that. But this would be just an additional resource if you needed it. And so the first sort of general comfort, sucrose, I think most are probably pretty comfortable with administration of sucrose, but there is lots of evidence that sucrose provides comfort, relief of pain related to procedures and otherwise. So we use sucrose pretty liberally, I will say. And then when we look at when we talk about end of life, the biggest concern when we counsel is about, I don't want my baby to suffer. I'm worried they're going to have lots of pain. What are we going to do for that? And so the standard approach, if non-pharmacologic methods are not working or sucrose isn't enough, is we use low-dose morphine. And we start with low doses and titrate up as needed for any discomfort or breathlessness or dyspnea if that is occurring. And you will see here there's morphine in the first top half is the oral solution, which is the commercially available solution. But the second half on the lower half of the screen is actually injectable morphine, which is in the typical concentration you would find on your unit. And you can actually give the IV morphine just in the cheek buccally. So that would be what a reasonable approach. And then sometimes fentanyl can be used through an automatizer like a MAD. We know that that may be and that's typically found in most emerges. It would be common to find that in the emergency department. So there is weight-based dosing for fentanyl for pain and discomfort as well, and how to draw it up based on weight. And then with regards to secretions at end of life, if this was occurring, you can use atropine eye drops, which are often sort of in the sublingually in the mouth. So they're the eye drops, but given in the mouth, and can help reduce secretions. And then the other thing that is rare but can occur is seizures. And there are certain conditions that put a baby at higher risk for seizures. But if we are providing end-of-life care, with no line, midazolam intranasally can be used for seizures or sedation if it's needed. And so these are initial doses, and you can titrate up as needed. You can see that in the comments and for administration. And even for things like fentanyl, it'll tell you if you need to mix it, how much to draw up of fentanyl and normal saline to get the concentration to make it be the right dose. So we try to sort of think this through to be as user-friendly as possible. But I think the reality is also, we don't, for a lot of the babies we don't need as many medications as people think, I think sometimes. So it is for most babies that we're supporting at end of life, we aren't needing to go through all of these, for example, to provide symptom relief, but these would be the common symptoms. But if there are any questions, then obviously we are happy to be a resource, but these were sort of initial management steps.
And in addition to the resource that Stephanie was just speaking about, we wanted to work together with the transport team to create an option to have a small, it's kind of, resource that can be provided to providers or the family that there's a little bit of memory making that can be done. It's certainly not really comprehensive, but there's certain things in this small box because it needs to be small for the transport team, which is really important because they have a lot of other equipment that is equally important as this, for sure. And really, it houses something that you can do handprints or footprints on. There's an interlinking heart within that is valued by many of our bereaved families, where the small heart usually stays with the baby and the large heart is with the family, and creates a connection for the family and their grief. Some grief resources, which would be for Roger Neilson Children's Hospice, and of course PALE. Is an amazing resource in our community. Measuring tapes, which can be also found, of course, in the hospital itself, and other things suggested would be like taking pictures and really encouraging that. And we have learned from families in bereavement that not having pictures was a really huge regret of theirs, and it was a really difficult thing and hard for providers to guide them through that. And really encouraging them to have, or offering them the crib card and the armband and potentially the blankets that baby wore and things like that. We also would love to be a resource for the entire community in order to create perinatal loss memory making programs or bereavement programs or grief programs within the hospitals in our region and beyond, if possible, and really just to help support this when there's any need for that. And that can be done through myself as the perinatal palliative care coordinator at RNCH. And, it would just be sharing information around what are some of the grief resources that we have and what can we use. What are some of the things that families have found really beneficial from a resource perspective, like supporting fathers, supporting grandparents, memory making supplies, where we can purchase them, where we can, how much are they, and what kind of a list does that look like, including keepsakes as well. And there's a lot of opportunity for donation in the community. There's so many wonderful people who want to knit for our little ones, or there's a wonderful organization in Niagara called Precious Angels, and they make beautiful white gowns for babies of all sizes, very little to very big, that are made out of donated wedding dresses. So there's lots of opportunity to create a small program within your hospitals as well, and I would love to be a resource for that.
And I think one of the other things that we wanted to highlight is that CMNRP does offer some education as well. So we do have a perinatal loss workshop where the target audience is really meant for healthcare providers who care for families experiencing any types of perinatal loss. Although it is a little bit more concentrated for the mother-baby unit nurses and labor and delivery nurses, which is typically losses after 20 weeks, it's still applicable to some of those early losses as well, and refers to some of the resources that are available more for an emergency department loss as well. But in a nutshell, just to give you a little bit more information on the workshop, it is a two-part workshop, meaning that it is done virtually. The first part would be that the participants would have to complete modules online. So we have a Google Classroom where they have like modules to listen to, videos and slides that they can learn about some of the content. And then we meet for 4 hours as well virtually through using a Zoom sessions. But we know that a big piece of the content that is very difficult for us healthcare providers is that we don't feel comfortable in the beginning. We don't know what to say. We don't know what to do. We don't know where to start. So communication is always a big piece of it. Just wanting to entail that the Pregnancy and Infant Loss Network, PAL, also has a free e-learning communication modules. And we ask our participants to go through that modules before they come to us and get the Zoom sessions as well. But just to give you a bit more information, we include content like grief responses, what could be expected, the culture and spiritual considerations, how to provide bereavement care, how to be compassionate. And we talk a lot about memory making, like Leslie had previously said, but also include self-care for the providers, because us as healthcare providers can be very hard emotionally to take care of a bereaved families when it's unexpected, or when you've had a really hard case, how to debrief about it, and what are the supports that are available for the providers themselves. And then we try to give a lot of resources. So what are the resources that families can use through a lot of them through PALE, but a lot of it through the Rogers Children's Hospice as well. And then when we get together, the Zoom portion, typically, this is where the participants love having guest speakers. So we are very fortunate that we have guest speakers, usually a family with lived experience, that will talk about their pregnancy loss and, you know, what did the staff do that was maybe hurtful or maybe helpful as well, so that they can learn from that. Because we all know that when we're uncomfortable and we don't know what to say, often that's when we will say something that could be perceived as hurtful to the families, right? So we do case studies about communication, and we also we're very privileged, as Leslie Sabourin comes always to be one of our guest speaker and talk about the Rogers Children's Hospice and their perinatal palliative program as well. So if you want more information, we offer the workshop the next time in May 13th, and we'll put the link to, if you want to see more information about how to register and what's the information there. But we just thought that we would give a little bit more information about the education that is available in terms of just helping out as well.
Thank you so much, Catherine. It is a wonderful workshop. I highly recommend it. I just wanted to briefly go over the grief services programming that we have at Roger Neilson Children's Hospice. And there is a link here as well to, if you wanted to navigate that a little bit more on the website. These are not all perinatal specific, but some are. We have individual counseling for families that can be, just mom, just dad, siblings, grandparents. We have perinatal loss grief circles, which are groups where families of perinatal loss come together in, usually 8 to 10 sessions of, guided by topics each week and facilitated by social workers here. We have one-on-one support for our siblings and as well as the grief circles and grandparent grief circles. We have a robust parent match program where in the perinatal world, families are so desperate to give back and really want to help those who are experiencing perinatal loss, given it is such a unique experience and can be quite isolating. And our parents are just so giving and want to help. And it's an amazing part of our program. And then we also support families in pregnancy after loss. Those who have gone through our program who become pregnant can attend monthly drop-ins just to kind of navigate that really difficult, unusual, complex experience of being pregnant again after having a loss. So we support families who have had a perinatal loss due to stillbirth after 20 weeks, those who have chosen to end their pregnancy, so termination of a pregnancy for a life-limiting condition over 20 weeks, and any parents who have experienced a neonatal death before the 20th day of life. So families can refer to our grief support and so can providers. So if you are a nurse at the bedside with a family or on the unit, or someone who is going through this, you can actually refer family. Physicians can refer social workers, and of course the family can as well, and they contact our grief service coordinator to schedule an appointment, and that is within our website, and it will also be on the pamphlets that is coming if you happen to have our pamphlets in the community. And when you meet our coordinator, she does an intake and assesses a family's need for what type of support really fits for them, and then they work with the team together to create a program for them moving forward. And that's it. And I have my contact information here, and anyone can reach out. And even if there's more questions after today about the program or anything coming up for any of the community providers, we're happy to take calls and emails, whatever is needed in the community. We'd love to take any questions.
Thank you so much, Leslie and Stephanie. I will double check again just to make sure. I don't see any questions in the Q&A, and I have not seen any in the chat box. So I will leave it to the participants just in case they are now getting to the question and wanted to ask them as well. If you feel more comfortable asking your questions by speaking, you can also raise your hand and we will allow you to speak and just ask your question. But we are so happy and fortunate to have such great resources like the Rogers Neilson Children's Hospice in our community and be able to help and support families. Especially, it's difficult for those rural community hospitals, like level 1 hospitals, when you have a patient that will, as you mentioned, will transition into end of life, or it's just a change of care, and then the team doesn't feel as comfortable providing care. So I think the booklet will be so much helpful for these professionals, just as a way to have a bit of resources and guide them on how to do and what to do, and also have the availability to call critical or speak to someone from the transport team, or even speak to someone from their children's hospice as well, just to kind of feel more familiar. And that's what we want. We want them to feel supported and be able to provide the best care that they can at that time, because it's such a difficult situation. And in that space particularly, right? So thank you. I think, we've just noticed that there's a bit of a typo here on the email. So maybe what we can do, Leslie, is if you want to share it with Charlotte in the background, and then we can make sure that we have the right email. We're just noticing that there was a bit of a typo here. So if you want to make sure, I think it's just the Rogers. Yes, I think we're missing the R after the Leslie Sabohai. So with that said, I'll ask one more time and leave to yes, thank you. So I just see that Charlotte has put it in the chat box with the correct email. maybe just give a few minutes just to see if you have any questions and leave it time for the participants. Okay, I don't see anyone. I just wanted to say a special thank you to Dr. Redpath and Gabriella and the transport team for just putting their input as well, and just giving some examples of what happens for you as the transport team, and what are some real life cases that you've seen, and how we can just learn all from your experience and work together as a team, like Leslie and Stephanie were saying, because we're just really trying to make sure that everyone can help out and give the best care possible. So thank you so much. We will put the video available on the CMNRP website in the coming weeks. Have a great day, everyone.
Thank you very much, Catherine.